All right, we're back into it. This is going to be Cardiology 3, Part 2. A lot of information covered and a lot of material that we've had to go over, that we had to break up Cardiology 3 into 2 parts. It's not unheard of, but again, we don't want to just take it to the deep end and drown you. So we left off here at the AV nodal blocks. So these are arrhythmias originating from the AV junction, which is, we've talked about how every impulse has an origination point and has identifying characteristics where we can identify who is pacing the heart. With sinoatrial nodes, we have that, appearance of a rust, which is a round, upright, symmetrical P wave, telling us that the SA node is pacing the heart. With any type of atrial rhythm, we can tell by its narrow complex that it is coming from the upper portion of the heart. Talk about, let's say, the SVT that we went over. It had identifying characteristics such as a skinny, narrow QRS complex, a lack of P waves due to fusion of the wavelengths, and then, of course, it is a rate of over 150. So there are identifying characteristics, and the best thing you can do for your patient is to follow your 5 steps of rhythm identification and pick out those inclusion and exclusion criteria to identify the breaks in the pattern for you to know which rhythm you're dealing with. So the AV node blocks or slows impulses. That is its job. And any arrhythmias that manifest themselves are due to a malfunction of those junctional cells there. So the node's going to produce either a first-degree AV block, second-degree type 1, Winkie-Bach or Mobitz 1. Yes, I said 3 different things. That block has 3 different names. The who, the what, the when, the why. The only thing I can surmise, which is more of a guess, is that Dr. A and Dr. B and Dr. C all wanted their hand in naming the thing, so they all was able to put their own spin on it. But here you are, sweet little paramedic student that you are, having to memorize 3 different names for 1 different thing. Welcome to medicine. Enjoy. Next, we have the second-degree type 2 or the Mobitz 2. Again, it has 2 names. Second-degree type 2 or Mobitz 2 is a higher degree block. And then you have the third-degree AV block, which is also known as a complete heart block. Again, it has 2 names. So third-degree AV block or a CHB, which is a complete heart block. Complete heart block. Let's talk about it. So a first-degree block is not actually a true block. It's a delay at the AV nodal conduction pulse rate. So each impulse is eventually conducted, but the AV node holds it longer than necessary. So it'll give you the appearance of a prolonged PR interval. Tell me what a normal PR interval is. Not. That's right. So 0.04 is the time interval associated with 1 millimeter blocks on the EKG graph paper. But a PR interval is the distance from the P wave to the QRS, normal being 0.12 to 0.20. So 3 to 5 blocks is a normal PR interval. So a first degree block is simply a longer PR interval because the impulse is being held longer by the AV node. Does that make sense? Not a true block, it just delays the conduction. Everybody follow me on that? What's that? If it's causing well, yes, the AV node is a delayer in conduction, and a first degree block would be just a delay in conduction. So is it possible to have a sinus rhythm with a first degree block?
Yes.
At a rate of 80?
Yes.
Absolutely. What about a sinus tach with a first degree block?
Yes.
It's possible, more rare, but possible.
Yeah.
It'd be hard to see at that speed, but if you're doing all your 5 steps, you can count that that P note, P wave is more than 5 blocks away.
Delay. Yeah.
It shouldn't.
It's not a full complete pump. Yeah.
So it doesn't affect the pump contractility. It just affects the electrical delay, and it gives the heart more time to fill up, actually. But when would it be a problem is if there is already a bradycardia on the table, if there's already some type of issue that's cardiac compromising the patient based on their rate being slower. And because it's holding that conduction longer, it's causing the rate to be slower, then it's something to be concerned about because it would probably cause a symptomatic bradycardia. at that point. So how do we treat a symptomatic bradycardia? High? Atropine is good, good, very good. If they're stable. I know. I didn't.
Of course, do. I stable or unstable.
No,
That's why I missed it.
but it's okay. Atropine's a good start. What's the dose?
Was it 2.8? 210?
Kill them.
Okay.
So 1 milligram, max of 3. So the entire pre-filled syringe.
No question.
But that wouldn't be my question.
If they have sinus tach at a high enough degree that the QRS is enveloping the P wave during a first degree block,
You'd lose it.
could it, yeah, I'm not saying, could you end up misdiagnosing sinus tachycardia as SVT?
If it's not visible and it's over 150 and it's narrow complex, possibly.
Well, it's more so, if it's going like 134 and.
No. You'd still be able to see it.
Really?
Yeah, at 150, I think I showed y'all on rhythm last week where it was about 140 something. And you could see the P wave starting to merge into the T wave with that fusion occurring, but
Well, I
it
mean,
wasn't,
If they have a first degree, it's going to elongate that PR.
and it could meld into,
Yeah, and it could fusion with the QR.
it could meld into it. It could,
Okay.
because it's longer out and it could be already fusing closer to the T wave. So atropine will be your symptomatic bradycardia stable. Unstable would be what? Pacing, dopamine, epi. Remember, pacing don't work all the time. All right, so next we have a second degree type 1, or known as the Winky Bach, or the Mobitz 1, or the second degree type 1. Now, this one's a funny little one because it has a longer PR interval, then a longer PR interval, then a longer PR interval, then it drops an entire beat. So longer drop, then you have a Winky Bach. Type 2, second degree type 2. I've only seen a couple in my career. They're not very common. At least in my knowledge. You might be one of them lucky guys that sees them every day. I don't know. Second degree type 2 is a high grade AV block. It's an intermittent block where it goes between stopping whole conductions and allowing others through. What does that mean? What does that look like? It means you're gonna have a bunch of P waves running around with no QRS behind them because the AV node was straight up said no. A secondary type 2, you'll have non-conducted P waves, which means there'll be P waves with no QRS because the AV node said no. Not in my house. No.
We have another one.
I don't know.
Whether they'll flood.
Yeah, 2-1 atrial flutter it could that, but with a Mobitz 2, it's more so it's like the P wave is going to continue marching even if it doesn't have a QRS. It'll just be like P wave, then you can have another P wave and actually QRS. Then you can have P wave, QRS, TP. So it's kind of like it just continues marching without the care of the QRS wave.
Me like it. So this is an intermittent block. Well, again, sometimes you'll see a QRS complex come through, and when it does, it has the same PR interval. It has a perfect PR interval. It's nice. It's wonderful. But then you'll also see the rhythm being irregular because there's some P waves that don't have a QRS following it. So far we've got the poem to help us. If R is far from P, then you'll have a first degree. Longer drop, then you have a Winky Bach. If some of the P's don't get through, then you have a Mobitz 2. And if R and P do not agree, then you have a third degree. So, yes, sir, I'll go back for you. Take your time, write your notes. You want me to drop my rhyme again?
Yeah.
You want my bars? Yeah. I also have it written down for you in a couple slides. You're good. So, a complete heart block is AV nodal disassociation. What does that mean? It means there's a total block at the AV node, which means the atria and the ventricles are no longer talking to each other. That means that you're going to have a rhythm that's going to be all over the place. But if you're doing your step 2, which is what, Walters?
Step 2, which is, I know, yeah, first is right.
Right.
It is like that.
Rhythm. Are we marching them out? So the QRS complexes are perfectly marched out. The P waves are perfectly marched out, but they have no correlation. So the atria is beaten, but it's beating on its own. The ventricles are beaten, but they're beating on their own. They're out of sync.
The QRS complex will be wide as well too, right?
It could be. Very well could be.
Why wouldn't it?
Should be. Let's take a look at a picture that helps you understand a first degree heart block. Man. So the dominant pacemaker is going to be who? The SA node, sinoatrial node. It sends a signal from where? SA node through the intranodal pathways to the AV node. AV node is supposed to hold that impulse for about 0.05 of a second. On a first degree block, he's holding it longer than he's supposed to, resulting in a first degree block. So it's regular, but it depends on the underlying rhythm because it could be anything. The rate depends on the underlying rhythm. Could it be a sinus attack with a first degree? Yes. Could it be a normal sinus with a first degree? Ish, because there's no such thing as a normal sinus with a first degree. It's a sinus rhythm. Could it be a sinus Brady with a first degree? It could be. So the underlying rhythm is what's moving that conduction through the heart, but it does have, in addition to a first degree, which it's more of an ectopic beat. It's just a delay in conduction. The P waves are pretty and normal, but then look at PRI. The PR interval is greater than 0.20 seconds. How many blocks is that?
0.02.
Well,
I mean, 0.2 seconds, that's 5 blocks.
okay. So 3 to 5 normal. This guy's going to have a greater delay. He's going to have more than 5 blocks. And the QRS is normal. Let's talk about it. First degree block. So as I go through my steps, the rate, blah, 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 it's a 6-second strip. Now I get to step 4, the PR intervals. So 1, 2, 3, 4, 5, 6, 7. Is that 35 blocks?
Yes. Past 5 blocks.
Beyond.
So 7
Yeah.
is more, right?
Yeah.
7.45.
The fireman, leave them alone. 7 is more than 5. So if it's 7, everything's perfect, but the PR interval's longer, right?
Mean that too.
So with a PR interval that long, this is a first degree block. That means that there's something in their heart causing a delay in conduction. The AV node is delaying the impulse. But he's got a rate of what? 70? Everything else looks pretty good. As long as his blood pressure and everything else is fine, he's stable. Do you have to mess with it? If it ain't broke, don't fix it. If you ain't gotta be that invasive, then don't. Now, if they got a rate of like 30, now we can talk about it. Rate of 70, good blood pressure, they're talking to you, they have no complaints. And observe and report at this point.
Can you release a patient on this? Like,
They might have it common, it might be a common for them. They might just walk around with it. AFib, people walk around with it every day. First degree blocks, people walk around with it every day. You know, is it concern for medical, cardiology clearance? They need to be seen by cardiologists. Is this news to them, or do they know they got, a delayed conduction in their heart? Do they know they got a first degree block? Or can they articulate that they've heard something like that before? Like how many times you went to a patient that had AFib, but they didn't call it AFib? Well, the doctor says I got like a, abnormal heartbeat. And that to them is them saying they've got AFib. Because again, doesn't mean they're stupid. It just means that they're not medically trained. This person might have a degree in mechanical engineering, but they're not medically trained. Let them ask you a question about mechanical engineering. Whoa. So describe me what a first degree block is. Tell me about it. That's it. Just delayed in the AV block. The AV node is just blocking and slowing that conduction. So everything can be normal or abnormal depending on the underlying rhythm. What's the big takeaway where I know it's an AV first degree block? That's it. If you're following your 5 steps, you'll catch that, right? You know who's sneaky? Well, me,
First degree.
sneaky first degree, but I sneak these in. Registry sneaks these in. They're just checking to see if you're going to follow your 5 steps, or if you're going to be just like a lot of these other ones out here, like, oops, this. Okay.
Actually, did you speak on this?
One of the portions of the National Registry is the static cardiology, where it's a 6-minute station. You got 4 rhythms. You get points for getting the rhythm right. You get points for treating the rhythm right. And you have to identify those rhythms to pass that station. That's part of the Paramedic National Registry. So, yes. And sometimes they'll sneak one in on you like, hey, this normal sinus, right?
We'll take that here, but
You'll take it here. We'll have it in-house. So if you're following your 5 steps, you'll catch that PR interval and you're like, oh, sinus rhythm of the 1st degree. So what about a 2nd degree type 1? We're talking about the Winky Bach or Mobitz 1, either one. It's got all these names. So how do I understand a Mobitz 1 is that I have to take a long look at the strip, not just one complex. I need to, if you've got a 6-second strip, evaluate each complex, each PQRST separately, and then evaluate that data and analyze it against each other. What does that mean? Complex 1 through 6, they got a heart rate of 60. I'm analyzing the PR interval on all of them. I'm analyzing if that's regular. I'm analyzing the appearance of each complex. Do they all look the same? Or is one wider? Is one shorter? Does one arrive prematurely and have big, wide, bizarre complexes like a PVC would? Or does one arrive earlier than expected and have a different looking P wave, indicating that it is a what?
one arrived early.
Yes, it arrives prematurely. PAC. So if it arrives early, it has this narrow complex, but it has a different looking P wave. We're looking at a PAC. So it is important for me to initiate the process for you to be strategic is to go through all your steps of rhythm identification and compare each complex. And that way you'll be able to recognize a Winky Bach as a progressively longer PR interval until it drops an entire complex, which means the PR interval is normal. It's a little bit longer. Now it's past 2.20. Now it's past that, then it drops the entire complex. It could drop it in 2 beats. It can drop it in 5. It'll have a longer PR interval until the whole heart misses a beat altogether. So the poem goes again. If R is too far from P, then I have a 1st degree. But longer drop, then I have a Winky Bach. You making notes or can I move? So the rules for Winky Bach, you will have irregular R to R. Why? The thing's going to drop a beat somewhere. Kind of like me. It will drop a beat somewhere. So the rate could be slightly slower than normal. Because why? It's dropping beats. We're missing whole complexes. That means we're missing a heartbeat. So this is not usually dangerous until we get into extreme bradycardia, until we have cardiac compromise, cardiac output dropping, because cardiac output is what? Heart rate times stroke volume. So the rate would fall because we're dropping beats. So the P waves that do come through, they're nice and normal. The PR interval, though, progressively lengthens until one P wave is not conducted. QRS is normally normal looking. I'll give you a second to finish your notes, and I'll show you an example of the Winky Bach. Y'all ready? Okay. Let's take a look. Ooh, the Winky Bach. So what we'll notice is P wave, it gets farther away, drops an entire complex. P wave, it gets farther away, drops an entire complex. Now this is a you know, a conduction pattern where we have longer drop. But it could be longer drop. It could be longer drop. It really just depends on the patient. So sometimes it is necessary to evaluate more than a 6-second strip. You know, you can do the 6-second strip to get your initial rate, rhythm, quality, but if you've got something funky going on, you need to run probably a 12-second strip, then run a 12 lead to get all that view from all these angles. Do you see where it's longer drop? And then we have the winky box.
What at first one they're looking at the draw is
Mm-hmm.
there's not a few ways before, right?
No, sir. It's dropping the entire complex, the whole PQRST, the whole heartbeat, gone. He's gone. So this is a, let's see,
I think the P wave is the first one that's hidden in the T wave.
might be.
So you got a P wave and then QRS complex, and that picks up on the P, QRS complex, P, QRS complex, and the P is right after the P complex.
I got more pictures. I know y'all need them. Let's take a look. So here's your P wave with, you know, longer drop again. There's your P wave, longer drop again. So as you can see on that top notch right there, that the PR interval is 16 on that first one. Let's take a look. So 16 will be how many blocks? 4 blocks. So we're 4 blocks, we're 5 blocks, then we're gone. Which means it probably went beyond 5 blocks, probably 6 or 7, and we dropped a beat. So 4 blocks, 5 blocks, gone. 4, 4.5. 6 blocks, gone. So the PR interval is 16, 18, 24, gone. 16, 18, 24, gone. Are you seeing the pattern? Winky Bach is consistent in that motion that the PR interval will be banging a ring where it's in a pattern that you can pick up. Who's lost on the Winky Bach? Again, the AV node is just holding. In my experience, yes. In my experience, yes. Another look at it. So there we got the longer. All right, go back. All right.
So I know the top strip, that's lead, like chest lead 2, right? What's the bottom?
It doesn't have a different lead. It doesn't tell us what lead it's in.
When we're practically doing it, we should we be looking at all leads or just lead 2?
So
the angle.
The process I would start with is do a 3 or 4 lead EKG first, get the underlying rhythm. And then I'll do a 12 lead to pick up any kind of ectopic beats, ectopy, or bundle branches, chamber enlargement, elevation, depression. That's where I'd look at all that at. But the underlying rhythm you can pick up here is in like leads 1, 2, or 3. But this strip is not giving us a direct answer to what lead that is. Everybody clear? Cool. Now, a second degree type 2 is a higher tier block. It's a higher tier block. So this guy is going to completely block a lot of the impulses coming out of the atrium. The ventricular rate will slow to about a half or a third of the atrial rate. So the atria is still pumping like it's supposed to, but the AV node is just not letting that impulse travel to the ventricles. So the ventricular rate will slow normally. So this is going to be a slower type of bradycardic rhythm that we'll have to deal with. So it selectively allows certain impulses through and others not. So this is why we'll have a bunch of P's running around without a QRS complex. Bunch of P's running around without a QRS complex. So the regularity of this is that it will not be regular. If there's drop beats, there's going to be an irregular R to R interval. You agree? Because there's a whole QRS complex missing. Atrial rate's usually normal, but then the ventricular rate's usually a bradycardia. Why would it be a bradycardia?
Over the
Come on, do better.
smart. They already, the ventricular already received slower, so it's even slower than.
Say that again. Answer the question again.
I was saying that the ventricular is already slower in comparison to the inward.
They should match. The AV conduction ratio should be a 1-to-1. Now we're looking at a 2-to-1, 3-to-1, 4-to-1 ratio where the atria is beaten 4 times, but the ventricle is only beaten 1. So this will result usually into a bradycardia rhythm. Now, when you do have P waves, they're usually pretty. There are always more P waves than QRS complexes in regards to a second-degree type 2. The PR interval on the conducted beats, conducted meaning that there is a QRS complex following it, will be consistent and constant. And the QRS complex will usually be normal and skinny. It would help you to look at one, would it not? This is a second-degree type 2. How do you know? There's a bunch of P's running around with no daddy. Just running around amok. There's no parental unit watching them. We can kind of see what? For this guy right here, look. Here's the little P wave at the park running around, but here's the parent watching them as well. These little bad kids are doing what? Just firing off for no reason. Whose kids are these? Where are your parents? Are you the parent? I'll tell you about pitching wood at work. Your hands nice and soft like a lady. Don't mess with the nurses. But then one of us went ahead and married one, didn't we? Fool. Yes, exactly.
She makes a shit ton of those names.
Gold digger. Definitely. So what we're looking at again, bunch of P's, bunch of little kids running around without a parental unit around. You have, is it regular? Is that rhythm regular? No, there are also 3 missing ventricular beats. So we got a rate of 50 up there. 1, 2, 3, 4, 5. And we got 3 missing beats. If those beats had got conducted, we'd have a rate of 80. 50 heart rate, 3 missing beats. So how do I know this is second degree type 2? Well, I got a nice PQRST on the conducted beats. I got extra P's. I got non-conducted P waves. I'm looking at second degree type 2. How do you treat a higher tier block? Will atropine work, Walters?
Are they stable?
Will they be stable with a heart rate of 50 and a blocked AV node? Shouldn't be. Come on, help me out.
Having to set the dopamine at certain levels to.
It depends on what you carry, honestly. A lot of places are phasing out the dopamine. There's a lot of studies that show that it's sometimes more harmful than good. For us, I would probably lean towards the epi drip. I mean, you can titrate that to the effects you want, and it seems to be much more useful in the body. It seems to work better, in my opinion. So I would lean towards that epi drip if I could. But for your NASA registry and your 2020 guidelines, your process is try pacing, then dopamine or epi. For y'all, it's an easy sell. If pacing don't work, epi's all you carry anyway. So make an epi drip. How do you do that?
1 milligram and 250 milliliter bag.
Either one works. 1 milligram, 250 bag, 2 milligrams, 500 bag. Throw a 60 drop set on there. With yours, the 1 milligram, 250 bag, you're looking at 4 mics per minute. With yours, you're looking about 8 mics a minute. I'd probably want to start lower and go higher because I can always put more in. I can't take it out once it's in the body. So again, I'm only looking for to get that heart rate up to 60, 70 beats a minute. I'm only looking to get that blood pressure up to 90 systolic. I just want to perfuse the organs long enough for them to do what? put a artificial pacemaker internally for this patient. These are the calls you run that people find out, oh gosh, I need a pacemaker, and then they get one. These kind of calls happen. Sometimes it's caught in a cardiologist's office. Sometimes it's caught in a paramedic cardiology office, which is your ambulance. So we're looking at, again, another second degree type 2 blocks. There's a 2-to-1, 3-to-1. There's a 4-to-1. Look at that. All them P's running around with no parent. So the ratio can change. It can move around. Look, there's a variable ratio at the bottom. There's a 4-to-1 ratio in this one right here. So what we can see is that we have an atrial rate of 90 with a ventricular rate of about 22 to 30. That 6-second strip, look at it, about 30 beats a minute ventricularly. Do you think that patient is going to be well perfused? You think that they're going to be able to meet the metabolic demands of their body? That's a no. Now, what about a 3rd degree or complete heart block? Well, it is what it is. It says what it is. I completely block all impulses that would like to travel to the ventricles. Absolutely, I will block everything. So what happens is that there's a regular rhythm. This is how you tell a secondary type 2 from a 3rd degree apart. 3rd degree is regular. They don't have anything blocking the impulse anymore because the ventricles are sending the signals. So the rate is usually normal. The rate is usually normal, at least in the P wave sense, but the ventricular rate is usually slower. About 40 to 60 if it's junctional in nature, about 20 to 40 if it's ventricular in nature. The P waves are upright and uniform. There's more P waves than QRS complexes. There's no PRI at all. There's no interval. They're just doing their own thing. And again, the QRS could be normal if it's junctional, which means the bundle of his or somebody is pacing the heart. But if it's coming from the ventricles themselves, it'll be slower and it'll be ventricular. It'll be wider because anything from the ventricles is what? Greater than 3 blocks wide. Everybody follow me? Feeling good? What are the rules for a 3rd degree? The rate will be probably slower, but based on the appearance / morphology of the QRS, you'll know whether it is a junctional complex or it is a ventricular complex, which means the AV, the atria is still going to pace itself, and then some pacemaker below the AV node will pace the ventricles. If it's skinny and narrow, we're looking at the junction pacing it. If it's from the ventricles, it'll be big, wide, and juicy. That's how you tell the difference. If the foci comes from the atria junction or the ventricles. P waves are usually pretty and upright. There's going to be a lot more of them than QRS complexes. The PR interval is going to be intermittent. It's not going to be something you can actually put your hand on. Now, the QRS, again, is going to be a variable. Who's running the show? Let's take a look at one now. Now, a lot of things that are common here with 3rd degrees is fusion. We spoke about fusion and it occurring. And with that, you can see that this rhythm is regular. It's a rate of about 50. And let's see if we can identify where the AV nodal dissociation in complete heart block occurs. So let's take a look. Got a little pin out. So, are the QRSs regular? Ooh. 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 All day. Now, what about the P wave? Ooh. Stuck on the T. P. Kind of fused here. Where's this one at? He's stuck off here. Look at him. Look at this little notch right here. You see him? Let me erase that so you can see him. Look at him. He's right there hiding in the butthole end of the QRS. That's a P. He's hiding over here in the butt end of the QRS. See him right there?
Yeah.
Look how he's different than this one.
Yeah.
Yeah. It's bouncing around. It's bouncing around a lot. And again, you'd have to take either your extra strip or a piece of paper and march these guys out. So if I marched out the P waves, P, 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 you see him? P, P, merge with the T. Look at him over here. He's merging into the front end of the QRS. They're not talking. They're doing what they're wanting to do. They're doing what they got to do.
So technically, you're gonna have errors in the script, just a matter of how big they are.
I wouldn't say how big they are. I'm gonna say where they're located in the complex is the challenge for you. So you'll have to determine what is fusion versus where it's actually at. And the best way to do that is to march out your QRS and to march out your P waves. This is why step 2 of your rhythm identification criteria that I gave you, rate rhythm, is important to do. March out your your Ps, then march out your QRS. Do both. You'll find this guy. What about this one right here? Now the lines here are boldened. See there? I've bolded and unbolded the lines. So what do you see here between these two? The P waves are perfect. Look how pretty they are. You can march them out. Now the QRS is perfect, but are they talking? No.
So the QRS wave, is that an inverse T?
Where?
Or just the S complex to repolarization the isometric one?
It's depression.
It's just depression.
Yeah.
Okay.
You'll see they're all doing it.
Yeah.
All these guys are depressed. Me too, Rhythm. Me too. Every time I get paid, I'm depressed. That'd be something. So we got our own thing brewing here. Oh, there's just the P's marching themselves out.
Would that be considered a horizontal ST depression?
Without having other leads to confirm it with. Again, it's okay. So here we are again with the 3rd degree heart block. P wave is there. T wave is there. It's hidden in the complex. You see how those two T waves are in those two first blocks on QRS complexes are taller? That's because fusions occurred. This is why you must march out your P waves. Why? There's a reason those T waves are taller, because there's P waves stuck up in them. And now for Chris Knott, my dropped poem beat. Oh yeah. The heart block poem. Believe it or not, when I take registry, I kind of hum this to myself when I reach a AV block or a rhythm that I think is an AV block. And just between us girls, I would say that anytime I have a bradycardic rhythm, I am going to cancel out and make sure it's not a heart block. So I will go through my steps here and I will make sure that it's not a heart block. I will, find the criteria for each, and then I'll make sure that it does not fit any of those criteria. So, yet one more time. If R is far from P, then you have a 1st degree, longer drop, then you have a winky block. Some of them P's don't get through, then you have a Mobitz 2, and then if P and Q's don't agree, then you have a 3rd degree. My heart block cheat sheet for your viewing pleasure. Heart block cheat sheet for your viewing pleasure. This is where you can tell them all apart. Stand them up next to each other. That's right. Feel free to take your pictures, or you could just download the entire PowerPoint, which I've made available to all of you.
If you don't stop using Logic.
Okay, I'll stop using Logic. I bet money that Not back there's got his PowerPoint pulled up. Good move, good move. Apparently there was some kind of trick to downloading it. Thornton figured it out.
Like right click on that, pull it up on a separate tab.
Yeah, something like that. So again, we can let you borrow a tablet. You want to borrow a tablet? You just got to sign it out and bring it back at the end of the year. We've done it before. You know what I'm saying? Honestly, if I didn't have this computer that the city gave me, I wouldn't have a computer at home either. So, I mean, if you want to borrow a tablet, we'll hook you up today.
Necessary because I got one that's essentially the same thing.
But are you doing homework on your phone?
Yeah, it's like they know something to do with shit, don't
That's why with them big old Coke bottle glasses on.
you know, I'm wearing these because my contact.
Just some trifocals. All right, so how do I treat a heart block? We kind of said it earlier, but I want to remind you and go over it again because pain and repetition and embarrassment is how you guys learn. So for a first degree and a secondary type 1, you can try atropine. If that doesn't work, pace, dopamine, epi. What about a high degree heart block? Tell me about it. You ain't got nothing, but try pacing.
Pacing that epi for the life of us, but you also got dopamine here.
If you carry it, you can try that. Or you can try the epi drip. For you guys, you'd probably run off that epi drip. You don't carry dopamine, which it's a pressor. You can use it as a pressor.
So type 1 is not considered high degree.
It is not. First degree and secondary type 1 are not high degree blocks. Everybody got it down?
Why are they not considered, what separation?
Well, there are more delays in conduction with one drop beat every couple of complexes, or just as a delay in conduction. Secondary type 2 and a third degree, they're actually completely blocking all impulses going to the ventricles to where we have non-conducted beats, and then we have AV nodal disassociation.
So one is misdemeanor, the other is felony.
There you go. I like that. This is pulled directly from the 2020 American Heart Association adult bradycardia algorithm. This is actually the page from your ACLS book that gives you an idea of what to do with this. Persistent bradycardic rhythm. Is there any hypotension, shock, ischemic chest discomfort, heart failure signs, or any kind of problems? If their answer is no, what does it say do? Monitor and observe. Roll on about your life. But if there is, you can try atropine, pacing, dopamine, epinephrine. That's the plan, man. It does. I'm not sure why we have not just scrapped it as a drug at this point.
But apparently it's good in the acute care, early hospital care.
Well, we haven't scrapped, but.
Digoxin.
Yeah.
All right, let's talk about these AV junctional rhythms. Oh, yeah. So when a higher pacemaker site fails, right, the AV junction is left with the responsibility. I was never intended to be king. Oh, I just came. Hey.
That worked out.
Yeah. But the AV junction is like, let's say the Queen of England died and like, dude, like 37th down the line was made the king. Like, I never planned to be king. Like, I know we was like cousins or something, but I live over here in like Bankhead or something, you know. I did not expect this. So when this higher degree pacemaker sites fail out, somebody's got to pick up the slack. Somebody's got to pick up the slack. So we have the AV junction that will kick in and depolarize the myocardium. Now, the unfortunate thing is that it will have a slower intrinsic rate at which it can depolarize. What does that mean? Usually it's got a slower heart rate attached to it, usually. So what we got going on is the retrograde conduction that occurs from that AV nodal conduction site. So high pacemaker fails, the atria are going to be depolarized, but it'll be retrograde conduction. So what does that mean that my P waves will look like? They'll be inverted because they're still being depolarized. It's just instead of electricity flowing this way down the heart like it's supposed to, it's going to go back up. Back towards a negative lead, back towards that vector will change, and it will cause an inverted P wave, or the P wave will be hidden in the QRS, so there'll be no P waves. This is how you know a rhythm's from the AV junction. It'll be either inverted or missing. Inverted or missing. So the rules for a junctional escape rhythm. We got 3 junctional rhythms we're going to talk about. Junctional escape, accelerated junctional, and then junctional tachycardia. Now, anything with the last name tachycardia has what speed at least? Over 100. Good job.
Look,
So, regularity. The junctional rhythms are regular. The rate for a junctional escape is 40 to 60. Now, this is very important. The differentiation that you will have for junctional escape, accelerated junctional, and junctional tach is the rate. At 40 to 60 beats, you're looking at a junctional escape rhythm. The P wave will either be inverted or missing. The PR interval can only be measured if the PR wave is there, and it'll probably be inverted. But the QRS is less than 3 blocks. This is how you know it's junctional. It's regular, it has an inverted or missing P, and it has a skinny QRS. It is regular, has a missing or inverted P, and it is regular. So again, the AV node will only take over if the SA node fails. If the king has died, we will move our way down the succession line. So when that impulse is generated in the AV nodal junction, it will travel down to the ventricles first and then back upwards towards the SA node to depolarize the ventricles. To depolarize the ventricles. So, believe it or not, I've had these slides a long time. How long? Since 2013. You know what? This information is still relevant. There's no need to go back over it. I admit freely this came from the Nancy Caroline Orange book. And you know what? The information ain't changed. So, you want to see one?
Yeah.
There we go. There's your junctional escape. How do I know it's a junctional escape? There's no P wave. It's regular. It's skinny, and it's got a rate of 40 to 60. It's not really diagnostic. It'd probably look like that because of the repolarization of the ventricles. Now, what differentiates a junctional escape rhythm from an accelerated junctional? Well, an accelerated junctional rhythm runs between 60 miles an hour to 100 miles an hour. Everything else is just like junctional escape. It is skinny. It is regular. There's no P's or it's inverted. The only difference in this guy is what? He beats off at about 60 to 100 miles an hour. What is wrong with all of you? You sicken me. Did I?
Yeah.
You guys disgust me. It's not true. I'm proud of you, actually. You get me. You get me. All right, so we've found that the accelerated junctional rhythm is regular. There's R interval being regular. There's no or missing or inverted P's. And then we have a skinny QRS. Now, this usually does not require a lot of free hospital treatment. It's about a rate of 60 to 100. It's just doing retrograde depolarization of the atrium. As long as there's no hemodynamic instability, you can let it ride. As long as the blood pressure is good, they ain't got chest pain, headache, or losing consciousness. They can breathe. If it ain't broke, don't fix it, please.
You mean they can ride to the hospital?
Yes.
Okay.
Hallelujah. So the junctional tachycardia that we're going to talk about. So everything is still like junctional escape and accelerated junctional. The one difference is now we're bucking off at 100 mile an hour. Or as we say in the South, mile an hour. Mile an hour. 100 mile an hour. I also know some Australian. Rise up lights. I shave with rise up lights. No? Rise up lights. Razor blades. See what I get for dating an Australian chick one time. So junctional tach, it beats off at about 100 miles an hour. So everything's normal. It's still got a regular R to R interval, still skinny. It's got a missing or inverted P wave, but it's just the rate is faster than 100. Everybody follow me? These are a little bit easier, I think.
Yeah.
Most definitely. All right, let's make it more challenging. So we also have pacemaker sites that can be a cause of a single irritable foci. Now, when we talk about irritable foci, we talk about ectopic beats, which are, again, out of the normal conduction system that have enhanced automaticity that will automatically spontaneously polarize the heart. We spoke about a PAC being a premature atrial complex. A PAC that occurs every other beat is known as atrial bigeminy. PAC that occurs every third beat is known as atrial trigeminy. Every fourth beat, atrial quadgeminy. But again, we can identify a PAC by it being an early complex that throws the regularity of the rhythm off, and it has a different looking P wave. Now, what about a PJC? Premature junctional complex. What do you think that looks like? Well, it again is a single ectopic beat, not an underlying rhythm that is there. It will also be a premature beat that arrives early, right? And that underlying beat will have a missing or inverted P. Missing or inverted P. What would that look like? You want to see? So a PJC is a early beat that is coming from the AV junction. A junctional complex has arrived. So what we see there is what? We have PQRST, PQRST, PQRST. Then we have an early beat. The heart beat earlier than expected. It came prematurely to the party. So how do I identify which premature beat it is? I can choose between PAC, PJC, or PVC. Missing or inverted? Do you see a P wave? It's not there. Is there an inverted one? No. So if there's a P wave there and it's an early beat and it looks different than the rest of them, that means some atrial ectopic foci cause the heart to beat earlier than expected. Now, in this case, some junctional foci cause the heart to beat earlier in this case. Now, PVC is the easiest one to see because it beats early, but it's also coming from the ventricles. So how does he look? Big, wide, and juicy, and normally has a inverted T wave because he's repolarizing in retrograde fashion because the foci came from the bottom of the heart. So PVCs are very easy to see because they're bigger than hell. They're also bizarre looking. They're wide and juicy. So let's go through it one more time. A junctional escape beat. Explain that to me, Walters.
So rhythm, the rhythm caused by the AV node, going to be lacking the P wave, and it's going to be at a rate of 60 to 80.
So let's go with junctional escape rhythm being a impulse originated below the AV junction that will have a regular R-to-R interval. It will have a skinny complex. It will have a missing or inverted P wave, and it'll have a rate of 40 to 60. Now, the accelerated junctional, so accelerated junctional 60 to 100. And then junctional attack is 100 above. Now, tell me about a PJC, not. Well, the rate can be anything. It could be a Brady, a normal, or it can be junction. It can be a tacky. So the underlying rhythm doesn't matter. This is a single beat. All up there, you mainly see what would be normally if that guy right there didn't exist. If he wasn't there, this guy right here, this would most likely have been a normal sinus rhythm. But this early beat right here threw off the regularity of this. So everything's normal except for this one complex. So the underlying rhythm here is still a sinus rhythm, but it has one ectopic beat, which is one irritable foci that is coming from where? The AV junction, because it has no P's here, and it's early, so it's a premature beat. It is a PJC. So this is perfect. Sinus rhythm with a PJC.
It's, it's coming from the AV node because it doesn't have a P wave, but it's also narrow because it was coming from the ventricles.
If it was coming from the ventricles, it'd be big, wide, and juicy. Yes. So this is how I tell a PAC, PJC, and a PVC apart. PAC, early beat, has a different looking P wave. PJC, it's either missing or inverted. PVC, it's big, wide, and juicy. That QRS complex is thick with 2 C's. Thick. That's how you differentiate between those three. Again, it'll be the cause of irregularity causing an early complex to appear.
I'd assume that as the AV node depolarizes, it probably sends electricity back up to the SA node.
Again, it would show up as either inverted P wave or it'll be missing because the fusion of that P wave entering into the QRS complex, just being swallowed by it. Bigger fish eats a smaller fish. You won't be able to see it. Yes, sir. So, not a problem. So PVC, PAC, PJC. A premature beat is a beat that just occurs early. Looking at this guy right here, he threw us out of whack because he came to the party early, right? So he's there early. So to differentiate between a PA, PJ, and PVC, we have to look at the complex itself. So this guy is skinny and normal looking, but he is missing a P wave. So that tells me that he's coming from below the atria. So if he's missing a P wave or has an inverted P wave, he's a PJC. If it's a PAC, there will be a P wave there, but it will look different than the normal round, upright, symmetrical P wave. And if it's a PVC, still an early beat, big, wide, and juicy. Everybody follow me? All right. We've made it to the ventricles. After this, we can close shop for the day, okay? You're doing great. I know this is a lot of information. Appreciate your patience. But you paid for this. So enjoy this brain rape. I'll give you a minute to write your notes and we'll get moving into the ventricular rhythms.
The twisted point.
Yeah. Still wake you up tonight.
Is it possible not to have a T1?
Yes.
Here's my here goes what you need. Is it possible?
There should be a T wave.
You will always have a T wave.
If there's a QRS complex, there's going to be a T wave, at least in my limited knowledge of cardiology, because what depolarizes must repolarize unless the patient goes into a cardiac standstill or something, or a VFib.
There is a flat T wave, and it could be up or down by 1 millimeter, and its possible reasons are ischemia and hypovolemia.
I can dig it. All right, so let's talk about it. PVCs are not a rhythm. They are a single irritable foci that's basically a pissed off piece of ventricular meat. It's possible that the heart's not getting enough oxygen. Maybe you did a couple stair steppers or whatever. But anyway, there's a pissed off piece of meat. And it is a single beat, not an entire rhythm. Single beat, not an entire rhythm. So again, it's one irritable foci, one pacemaker site, like let's say this guy right here, who's irritated. So he's going to spontaneously depolarize. He's going to cause the heart to beat out of turn and to arrive early, to have a complex arrive early. So they're most likely a sign of myocardial irritability. There's multifocal PVCs and there's unifocal PVCs. Now, unifocal PVCs are PVCs that are coming from the same irritable foci. What does that mean? You see back on my picture here, right? There's one little site of pissed off cell there. Multifocal PVCs means that they're coming from all over the place. So like here and here and here and here. So unifocal would all look the same. Multifocal would all look different because they're coming from different pacemaker sites in the myocardium. So PVCs, again, are irritability. Multifocal PVCs, when they're all coming from different directions, that's a much more serious sign. Usually means more of a poor prognosis for our patient. Now, runs of VTAC is sometimes a event that happens that's called salvos. A run of VTAC is called a salvo. What is a bunch of PVCs in a row? It's a run of VTAC. Couple PVCs in a row is a run of VTAC. It is a sign of myocardial irritability. Could be acidosis, could be drugs, could be hypoxia, could be a lot of things that are causing this patient to have irritated heartbeat. Any indication, though, should be carefully and aggressively managed. Now, a lot of times you'll pick up a patient that might be, let's say they call you for a CHF exacerbation. That means that they have a supply and demand issue. The heart has not the ability to meet the metabolic demands of the body, and the heart's having some issues oxygenating and feeding itself. So the heart will throw PVCs sometimes. You know a way I can get rid of them sometimes? Sit them up high in a high Fowler's, put them on a nasal cannula and let them just rest a few minutes, and sometimes it'll go away. I didn't have to do any big paramedic-y things. I just had to do some simple BLS basic things. That's it. So what does a PVC look like? Big, wide, and juicy. How do I know that's a PVC? Well, it's big, wide, and juicy and bizarre looking. Exactly. It's way out of proportion. So you've got a normal kind of rhythm, then you got these PVCs showing up. PVCs are much easier to see than a PAC or a PJC because it doesn't require as much attention to the detail. You just suddenly, when I first turned to this rhythm, when I went like that, you was like, oh, there's a big break in the pattern there. And that's what we're seeing, is that there's a break in the pattern. There's a huge complex that exists there. So we have a PVC occurring. Remember, a run of PVCs is called salvos. Multifocal means that all the PVCs look different. That is more of a sign of danger for the patient. Now, what does unifocal PVCs look like? They look the same. They're coming from a single one ectopic foci, one pissed off piece of meat. They look the same. Now, what if they're coming from different sites? Multifocal, meaning multiple sites, they look different. They look different. That means there's more than one site of irritable, pissed off ventricular meat that exists right here for this patient. Yes. These kind of calls you will run. So when we talk about, I'll get there in a minute. Now, what about if there's two in a row? They're called a couplet. A couplet is a pair of PVCs right there. So, Walters, is that a multifocal pair of PVCs or a unifocal? They look the same? That is unifocal. That comes from one irritable foci. What happens when these guys kind of group together and hang out? Okay, there's two of them. Now, what about a couple of them, 3 or 4? No. A PVC is occurring in a run is what? That's a run of VTAC. That's a run of VTAC. It's called a salvo. It's a run of VTAC. It's called a salvo. How do I know that's a PVC? It's big, wide, and juicy. It's also pushing down. Why?
So it's going up back towards the negative lead, causing the line to go this down.
Very good. So they're pointing down. Why? Because the Purkinje's are the ones firing off like, hey, I'm gonna shoot this thing off. And it's causing the heart to beat off. Now, we do have patterns that exist, though, right? We had earlier when I told you that every other beat being a PAC was atrial bigeminy. What about every other beat being a PVC? That's ventricular bigeminy. So every other beat is bigeminy. So every other beat, I got a PVC. What about every third beat? That's ventricular trigeminy.
Ventricular trigeminy.
Patients exhibiting a run of salvos and couplets and ventricular trigeminy. Actually,
Nurse on the other end of the phone, like, what? The nurse is gonna be like, I don't know. From my wife, I don't know fucking rhythms.
they're usually not very good at EKGs. No.
The doctor could have, fuck that.
Indeed.
They literally told me that that's the reason they got paramedics in. So the paramedics
Accurate.
interpret them.
Accurate.
One of those nurses aren't even trained, read rhythms in one.
Interesting. What about every fourth beat? We're looking at ventricular quadgeminy. So there are rules for the PVCs. The rules really kind of wind down to the QRS complex. There is an underlying rhythm. Find out that first. And then you'll notice at the bottom, the QRS complex is wide, bizarre, and it's greater than 0.12. The T wave is usually opposite. Why is it opposite there? Not so repolarization, sending signal back to the negative electrode. Yes, very good. So usually wide and bizarre. There's your 5 questions asked. What did I give you for rhythm interpretation? Rate, regularity, P wave, PR interval, QRS complex. Every one of these things, these rhythms I'm giving you, you can identify if you follow the 5 rules and you take your time and you do it right. Here is a premature ventricular complex, contraction, as it were. Sir?
Well, just because it's big wide and juicy, yes, it's ventricular, but it's R wave is higher than the R wave, so I'm assuming it's fused with something. Or is it just the amplitude?
Of the ventricle. It's slower, but it's got more juice. So we can tell this is a PVC how. It's big, wide, juicy, and early. So what happens when all other pacemaker sites of the heart have shut down? Or what happens when you get a patient back from a cardiac arrest and they enter into a reperfusion style rhythm where only the bottom of the heart's trying to kick in? These type of rhythms are known as idioventricular. They're big, wide, juicy, and missing P waves and have inverted T waves. What does that look like? That. Ugh. Gross. These are your idioventricular rhythms. They're big, wide, juicy, have no P's, inverted T's, and they are slower than Christmas. A idioventricular rhythm, or a ventricular escape rhythm, as it's known, will be slow. It will run 20 to 40 beats a minute. Anything less than 20 beats a minute, we will deem as agonal. Anything less than 20 beats a minute, we will deem as agonal. What does something mean to be agonal? You said it was useless? So it's like death throes, like last ditch effort before cardiac standstill. So in the absence of all higher pacemakers, the ventricles themselves will try and initiate an impulse at their inherent intrinsic rate as a way to try to prevent a cardiac standstill. What's that? That rate, 20 to 40 for idioventricular escape or ventricular escape. It really depends on what caused it. It could be the patient lacked volume, went into shock. It could be the patient was in a cardiac arrest. You got them back. A lot of the rhythms you get back from cardiac arrest are not pretty. It could also be that the patient had a lot of that upper heart tissue die due to a MI. It could be a drug thing. Acidosis could cause that. There's a lot of different things, really. So what do we also notice? It's regular. You know, it's slow, like Christmas, but it's on time. It's slow. It's regular. It's missing P's. It's wide. It's juicy. It's got an inverted T.
That's the station. I was gonna get farther away, I gotta go with that.
Depends on the patient. A lot of times it'll just slow down to nothingness and settle into a systole. If the heart has enough, let's call it juice left, it might switch into like a arrhythmia to try and save itself.
That. Then there's flagging stuff out.
Depends on how many catecholamines I think the heart has left. You know, the body has left. Like how much adrenaline you got left, and how much, you know.
Those just go space out to nothingness, or they go on the deep tag and detail.
There you go. So idioventriculars are also known as ventricular escape rhythms. They're the last ditch effort to prevent cardiac standstill. SA node and AV node have failed. We're at the very bottom of the heart. The rate is usually less than 40. So they're usually caused by extensive myocardial damage, secondary to acute MI, or the failure of the higher pacemakers. These are lethal. These must have immediate and very aggressive treatment. Now, what did I say about an agonal rhythm? It's when the idioventricular falls below 20. It's usually seen as a last ordered semblance of the heart trying to do what? Pump blood. Also, when either resuscitation is unsuccessful or after successful defibrillation. When you do get a pulse back or a defibrillated patient, this is what you can look at. So next I have your 5 questions answered there. We got a rate of 20 to 40 for a ventricular escape or idioventricular rhythm. There's no atrial distinguishing marks. There's only ventricular rhythm, but it is regular. There's no P's, there's no PR interval, but the QRS is big, wide, juicy, bizarre looking. Idioventricular, again, is big, wide, and juicy. Now, what happens now? We talked about idioventricular rhythm or ventricular escape. That runs 20 to 40 beats a minute, right? Now, what about 40 to 100? When it hits over 40 miles an hour, it is now an accelerated idioventricular rhythm. Between 40 and 100, we have accelerated. Now, what do we still see? It's regular. There's no P's, no PR interval. It's big, wide, juicy, greater than 3 blocks wide. But it runs at 40 to 100 miles an hour. Now, what if this ventricular rhythm runs over 100 miles an hour? It is VTAC. That is VTAC as it graduates. Point, 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 point.
Are any of these rhythms actually
Define getting the job done.
You're
Like,
not dying right now.
you can have VTAC with a pulse. The patient may compensate for however long. Also depends on how aggressive and immediate your treatment is and recognize it. Remember, my thing that I push on you is that EKG is a normal vital sign that you should have a patient on leads within the first few minutes of meeting them. Like, let's say we respond to an unresponsive male patient on the side of the sidewalk. As we're going, sir, are you okay? Blah, blah. He does have a pulse. Let's just put him on the leads. Let's look at this, blah, blah, blah. I'm going to get all the information in the first few minutes of meeting him. Let's not shock it unless they don't have a pulse.
What are there is electricity getting back to the SA or to the AV node? Where the arrows are pointing.
I couldn't tell you. It's just too much data. An epi drip on VTAC? Let's not make that faster and kill them. Anything that's too fast, you don't want to give anything to make it faster, unless you want them to die. If they have VTAC without a pulse, shock them. You can defibrillate them. But if they have VTAC with a pulse and they're sitting here talking to you, then you're going to want to look at some amiodarone. About 150 milligrams, 100 cc bag over 10 minutes is what you're going to look at. If they're stable, VTAC, amiodarone. If they're unstable, synchronized cardiovert. And then I would call for orders to hang some amiodarone. That way they don't go back to this.
If they have a pulse, stable, or you say if they unstable with a pulse?
If they have a pulse, they're either stable or not. If they're unstable, they'll have a low blood pressure, decreased mentation, chest pain, difficulty breathing, pale, cool clammy. They'll be showing signs of shock and hemodynamic compromise. That's unstable. We'll go straight to synchronized cardioversion. If they're more towards a stable, like I just don't feel good, then you put them on monitor, you're like, oh, you say you just don't feel good? Yeah. What's the blood pressure? Normal? Oh God. Now, is this going to stay stable long?
No.
Probably not. So we need to get aggressive. We're going to start an IV on you, okay, buddy? Oh, what for? I want you to feel better. I'm gonna make you feel better. I got medicine. I got happy juice. Please let me start an IV. Please.
And that's getting off quick because their myocardial cells aren't gonna last for long.
No, he's gonna run out of juice, and he's gonna then be VTAC without a pulse.
For the time.
But at least he's quiet then. So that is how we would manage heme. The VTAC still carrying on with that. We're saying that this is a rhythm where 2, 3, 4, 5 PVCs have done banded together, and they have overridden the normal pacemakers of the heart. It can occur rapidly and be initiated by a PVC or by a bunch of PVCs in rapid succession. Just know that PVCs appearing is an opportunity for that ventricular ectopic beat to take over the whole show. So if you see a patient out there with some of these going on, understand that it's not a good thing. It also could be a sign that they could be deteriorating rapidly. If that rhythm is sustained, it could make the patient deteriorate very rapidly. Now, it could just be a run of VTAC. A sustained rhythm is one that lasts for about 30 seconds or more. If it lasts less than 30 seconds, Walters, we'll call it non-sustained. Is a non-sustained rhythm or simply just a run of VTAC. You gave it a run, gave it a try. So again, a sustained rhythm or a VTAC that sticks is lasting more than 30 seconds. And one that doesn't last more than 30 seconds is non-sustained. It was just a run of VTAC. Still scary, still ain't great for the patient, but it also is signs that a patient could deteriorate rapidly. So it's classified based on the patient's assessment. Is it pulseless VTAC or a VTAC with a pulse? Well, how do you know? You check a pulse. I know it sounds simple, but there's always one of you crayon eaters that'll goof it up. So there's VTAC with a pulse, VTAC without a pulse. The one without a pulse is usually easier to spot. Why? Patients usually, there you go. The patient's usually laying on the ground, trying to be unalived. So pulseless VTAC, you need to defibrillate that. There are two shockable rhythms. You defibrillate pulseless VTAC and ventricular fibrillation, VFib. So the treatment again will be based on whether they got a pulse or not. Now, when we get ACLS here in a couple of weeks, we'll talk about the importance of priming the pump, which is CPR is the most important contributing factor to a patient being resuscitated versus not. I don't care how special of a paramedic you are, what drugs you push, and all this other crap. If the CPR, the chest compressions ain't perfect, you ain't getting nobody back.
That's the way to figure out if the compressions are adequate is through color or through entitled CO2.
All that. So capnography is the best way to see if your compressions are worth a toot or not. You should have at least a reading of 10 on your capnography to let you know. All right, the rules for VTAC. It's usually regular. VTAC's regular. It's fast as heck. There's no P waves. And there's no PR interval. So it's big, wide, juicy, greater than 3 blocks wide. T waves usually the opposite direction. Now, treatment of VTAC is based on patient's clinical picture. Are they stable or nah? So VTAC with a pulse is based on stable versus not. Unstable will be low blood pressure, shortness of breath, or chest pain, or pale, cool, clammy shock. They're losing their mentation, their level of consciousness is dropping. You would immediately jump to synchronized cardioversion. If they're stable, they got a normal blood pressure, no chest pain, no notable change, you can try drugs. What drugs do you say? Amiodarone, class 3 calcium channel blocker. Option A, 150 and 100 bag over 10 minutes. Option B, you drop all 150 in a 10 ml syringe, you give 1 ml per minute. But that means you're going to be sitting there like this. The minute up, push. Next minute up, push.
So what can we expect us dropping that in?
I would drip it.
What can we expect us dropping that in?
Over 10 minutes, you can hopefully expect to see that rhythm stabilize into a more life-sustaining rhythm What amiodarone will do is it will coat that irritated ventricular foci, decrease its automaticity, relax that ventricle, delay repolarization, and form some cardioprotection there. It should keep them from going to VTAC without a pulse.
I mean, but they gonna stay in VTech at that point, or?
It's possible he can convert. The main thing is I don't want him to go to the VTAC without a pulse. Hopefully he'll convert with the administration of the amiodarone, which should slow those conductions through the heart. And again, that enhanced automaticity that we got going, it should suppress it. Amiodarone's job is to suppress ectopic foci. VTAC is an ectopic foci that just took over the entire beating of the heart. Hopefully, if we suppress that little bastard, we can do what? Have the SA note, hey, you can come back to work. It's okay. The bully's gone.
So this is, so the amiodarone is gonna slow it, it should slow your rhythm.
It should slow it down and suppress that pissed off ectopic beat. Yes.
So there's no way it's gonna slow it down to where it's at.
Should not.
And then just, make sure I'm on the same page with the unstable VT is the polymorphic.
Polymorphics, torsades to points. What you're looking at right now is probably going to be monomorphic, and I'll cover both of those here in a minute.
And then why not, it's also saying, emerald, oh, I might hear next one. Right. Okay.
So the treatment for this is going to range from amiodarone to procainamide to sotalol. None of you are carrying procainamide or sotalol, but AHA and National Registry, it'll be there. So when you're in here doing scenarios, feel free to say things like procainamide or sotalol, or feel free to treat a patient that needs a surgical cric with that. But just know that when you become a Georgia medic, that's off the table for you. Procainamide, like lidocaine's brother, is a sodium channel blocker. Sotalol sounds like a beta blocker, don't it? But it is a potassium channel blocker. I know, threw me off too.
Hey, quick question.
Yes.
Book also talked about verapamil and downtown.
Verapamil. So we're talking about calcium channel blockers, that they're an option for stable tachyarrhythmias. They work better for the atrial tachyarrhythmias like SVT, sinus tach, multifocal atrial tachycardia, things like that. I haven't seen them in a protocol for VTAC. Diltiazem. That's cardiazem. It's a calcium channel blocker.
So why procainamide over iodine?
Really just what you carry.
So you could consider lidocaine over procainamide?
We used to, yeah. So VTAC, how do I know that I know that I know? It's fast, boy. It's fast. There's no atrial distinguishing there. There's no P wave. There's no PRN. It's big, wide, and juicy. And all the complexes look alike. What do you mean? If it's monomorphic VTAC, it's coming from one singular pacemaker site. What does that mean? There's one pissed off pacemaker site, and that's why they all look the same. Mono versus polymorphic. So, Walters, you got one girlfriend. Y'all are monogamous, right? You have several girlfriends. You're polyamorous. So you just out here just hoeing that thing around. So monomorphic VTAC is one site. Polymorphic VTAC or torsades is multiple ectopic sites that are pissed off, and that's why it looks like a twisting of a point. Torsades, they point. It's French for turning on a point. It's also known as polymorphic VTAC, poly meaning many. So it's got many pacemaker sites. So monomorphic VTAC all looks the same. They are all coming from the same spot. It's big, wide, juicy, and fast. Do you see any P waves? Me neither. Is it regular? Yes. Is it over 100? Yes. Its name, VTAC. Stable VTAC, run them with the amiodarone or the procainamide or the sotalol. Unstable, synchronized, cardiovert. VTAC without a pulse, run the cardiac arrest. CPR, defibrillate, epi, amiodarone, intubate, get you a line, look for H's and T's. Cycle, circle, circle. Now, torsades de pointes, or polymorphic VTAC, causes prolonged QT syndrome, which could be congenital, but most likely it's from either drug-induced or it's acquired through electrolyte disturbances, hypomagnesia, hypokalemia, hypocalcemia, bradycardia, heart disease, antiarrhythmic overdose, antipsychotic overdose, antiemetic overdose, antifungals, antimicrobials. Wait, is there an antiemetic that we carry that causes prolonged QT syndrome? Wait, we do carry Zofran that does cause that, which could cause torsades, which is polymorphic VTAC. Take a look. Monomorphic, all look the same. Polymorphic, all look different. That's because there's multiple pacemaker sites firing off. So imagine, if you will, there's a bunch of sparking wires at the bottom of the ventricles, and they're all trying to take a turn to run the show. I'm the captain. No, me. No, me. I'm telling mom.
What's up? Why did we reach that point where it's smaller?
It's just the amplitude of that pacemaker site didn't have as much power, as much, amplitude. So polymorphic, monomorphic, all look the same. Poly looks all different. Questions?
So both of them are killing you, right?
Both of them are bad, yeah. You can actually have a pulse with torsades. Not long, but you'll have one. So the reversal agent for torsades. The drug of choice for torsades, mag sulfate. Mag sulfate. This is the only arrhythmia that I'm going to tell you about that you'll treat with mag sulfate. 1 to 2 grams, 100 cc bag over 10 minutes. Put it in their body. It'll protect them. It will hopefully convert this rhythm. So the rules, similar to VTAC, it is still a VTAC of sorts. Morphology shows variations in shape, size, amplitude all over the place, resembles a turning or a twisting motion from baseline, may result from hypokalemia, magnesium, tricyclic antidepressant overdose is a very common one, and the use of antidysarrhythmics. So TCA overdose is a very common cause of torsades. So the best thing you can do is to find and treat the underlying cause, throw some mag on them. And the key to recognizing torsades is the variation of QRS morphology and shape, which means notice that they all look different. To me, it looks like, in some cases, a perfect one looks like a sound wave or a DNA strand, like so.
Yeah,
What's that? You can see sound waves now? Yeah.
you shot that.
You can defibrillate it without a pulse, yeah. Could you cardiovert it? Why?
It says 100. So you can, the shock of 100 joules, with no response to the first shock, the same, that should be free.
If your book says that, we'll go with it, but I've never seen a protocol that allowed you to cardiovert torsades, because you would never be able to lock on at the right time. It'd be very, very challenging. So the main treatment we have is going to be that mag. Mag is the guy. Hopefully it'll convert it back to a sinus rhythm. Would be. Because again, the goal of the mag is to suppress those ectopic foci, relax them, and then let the SA know, be like, hey, come on back to work. The bully's gone. So mag is your option for torsades. Torsades, mag and torsades. They're best friends. Get to know them.
There is very little chance of both the AD and the sinus like legit going kaput at the same time.
Say that again.
There's precious little likelihood of both the SA node and the AD node canceling prisoners at the same time. And
There's got to be somebody dominating. There's a dominant sub.
like
Somebody's going to be running.
like both going out, like they just stopped working.
There is a complex we spoke about earlier, like the 3rd degree block, where they're doing their own thing. So that's a possibility.
But I mean, well, I guess if the tissue died,
Maybe.
it's unlikely otherwise. All right.
So the last rhythm we'll talk about, then I'll cut you for the day, and we'll conclude Cardiology 3, is going to be your ventricular fibrillation. Notice the green stars. This is a fatal dysarrhythmia. They will not have a rhythm. This will occur and have sudden cardiac arrest. There will be no pulse. This is usually cause of multiple weak ectopic foci. Myocardial cells are going to quiver and not depolarize. That means that all them little myocardial pacemaker sites are all quivering and they're not depolarizing. They're not doing anything. They're not transmitted along the normal pathways. They're all trying to run the show and they can't all do the same thing at the same time. So waveforms will appear disorganized. There is fine VFib and coarse VFib. Fine VFib has got a very low amplitude of less than 3 millimeters of amplitude. That's 3 little blocks. Coarse VFib's got a lot of power and energy. It's got more than 3 blocks of height. Now, what does fine VFib look like? Looks like that. Could be a systole with artifact. It could be just very small, squat, little VFib. Again, it's less than 3 blocks tall. Now, of course, VFib has a lot more amplitude, a lot more chaos. It's all over the place. It is greater than 3 blocks. There's a difference in coarse and fine. Which one do you think occurs first?
Course.
Why?
Because they have a lot of energy.
A lot more energy, right? As the cells get weaker and die off, like you can see where the amplitude just goes, shrinks down. Again, I want you to treat your patient, not the monitor. Again, it could be from an MI, hypoxia, drug toxicity, overdose, hypoxia, something like that. Treat the patient, not the monitor, because enough artifact can cause the monitor to scream VFib. Now, how do you treat VFib? What does it need?
Shock.
It needs shocking. 4. Interesting. Why we all look alike? I don't have a brother. I am looking for one though. In Texas. So how do I treat VFib? I need CPR and I need to defibrillate it. What are my 2 shockable rhythms? VFib, pulseless, VTAC, VTAC. This will also be one of the rhythms that gets an antiarrhythmic during your CPR and cardiac arrest. That'll be your amiodarone. Question.